Good morning, everyone. Central Florida Parent Center would like to welcome you to our CFPC webinar. We are the Parent Training and Information Center, the PTI. We're funded by the U.S. Department of Education, Office of Special Education Programs. Our project is AWARE, assisting with achieving results in education. And I'd like to also introduce Lynn Sear. Lynn, are you there?
I am. Good morning, everyone. It's my pleasure to introduce today's speaker, Dr. Sheryl Logan, MD, board certified, has been in practice since 1995 with OB and GYN specialists, the Division of Women's Care, Florida. She has expertise in minimally invasive gynecologic surgery, high-risk pregnancies, advanced ultrasonography. You can tell I don't have a medical background. Infertility evaluation, menopause management, and preventive care for women. Dr. Logan received her medical degree from the University of Miami Miller School of Medicine and completed her residency in obstetrics and gynecology at Arnold Palmer Hospital for Children. Dr. Logan is board certified in obstetrics and gynecology, and she is a fellow of the American College of Obstetricians and Gynecologists. Dr. Logan is the mother of 3 boys and enjoys just about any outdoor activity, including cycling, hiking, skiing, and gardening. So without any further delay, I would like to present to you Dr. Sheryl Logan.
Good morning, everybody. I will get my screen up for you. Can you guys see my screen now?
Yes.
Yes.
Okay, we're good to go. Well, thank you so much for having me. I will tell you guys that this is my first webinar experience, so bear with me. We will have some stops along the way to answer really any question that you want to throw at me. And if I don't know the answer, I will find a way to get back to you and answer it. But we're going to go through the basics. I feel so fortunate to be in this town. Really got to know some women with Down syndrome after being on the Down Syndrome Association board for many years, and love to see these women as my patients, have a special interest in taking care of these women with intellectual disabilities. That's really most of the experience that I have, and I'm learning more along the way. And I'm sure that you as parents will certainly help me learn as well. And hopefully we can get other doctors in this town to learn what they need to know to take care of your daughters. So what we're going to discuss today are just the basics. And then I expect that you may have some really more specific questions for me. But we're going to just run over what puberty is. Premenstrual syndrome usually goes along with that, just key things to look for. We'll talk about sexuality, and we're going to go through birth control options in detail. Pelvic exams and pap smears will answer the burning questions that I'm sure that you have about whether it's worth it to put your daughters through these exams and when and why. And then we'll talk about a few gynecology concerns that it may come up more specific to your daughters based on their medication use and their medical conditions that they have. So puberty, that all of us remember, is a really awkward time, but it's basically the time that your body is sexually maturing and you're on your way to becoming fertile so that you can have babies down the road. Puberty starts at different times. In girls, usually it starts between the ages of 10 and 14. There's some variation. A lot of times, body habitus, whether somebody's weighs more or less, activities, medications, genetic factors, family history, all of those things can play into whether puberty is early or late. Puberty is when you develop your secondary sexual characteristics. So these are all the features that distinguish us as adults between men and women, the things that we identify with being female or male. There are some people that go through puberty very early, and that is a term called precocious puberty. And generally, if a girl goes through puberty at around age 7, that's considered precocious or early puberty. And again, there are a lot of factors that can cause that, including genetics or family history or medical conditions. Some of the things that show up during puberty, as we are all aware is acne, and that has to do with hormonal changes in the skin where the glands are forming and the sebaceous glands become clogged. Some women get anemia in their puberty years. Sometimes it's from losing blood during their periods, but sometimes it's just that they're not getting a good diet that's high in iron. Boys usually don't have that same problem, but with the girls they do. So it is important to make sure your girls are eating some iron-rich foods during that time. Sweat glands start to really develop. Moodiness definitely develops. Some of the girls start showing signs of scoliosis where their spine is curved, and that usually happens just because of rapid growth at that time. Some women have vision changes. They might become more nearsighted at the time of puberty because of changes with the eye from the hormones. It's also a time when people can injure themselves. They become a little bit more accident prone, and the muscles and bones, since they're growing and changing so much, are really prone to sprains and even some fractures. You have to be careful. With the girls, of course, during puberty, they start to have their periods, and one of the very common things to see is that they have some very irregular periods in the beginning. Either they come once and not again for 6 months, or they come too often. They can last too many days, meaning more than 7. Some girls will have a period and then they don't ovulate or release an egg for months, and so because of that, their period won't come. And these are the girls that I usually see in my office quite a bit. They get referred in from pediatricians because they have 1 or 2 periods and then nothing happens. Or on the other side, they have too many periods and they're bleeding all the time. And when you're a teenager, and at any age, but especially when you're a teenager and you're new to this, it's not fun to go through. Some girls go through delayed puberty, which is a late onset of puberty. And in the medical community, that's usually defined as somebody that has no breast development by around 13 and a half years of age. So if nothing started to happen around that age, that would be called delayed puberty. Sometimes it's something that just runs in families and is not a problem at all. But if you're seeing your pediatrician, I'm sure that's something that they're watching and will let you know. Some chronic medical conditions like diabetes, cystic fibrosis, or even thyroid problems, pituitary gland problems, malnutrition, those things can cause a delay in the onset of puberty. Also, the girls who exercise a lot, who have very low body fat percentage, a lot of the gymnasts that you see in the Olympics, those girls have a very delayed puberty because they have such a small amount of body fat. The hormones haven't kicked in yet. So a lot of the competitive athletes will have that be an issue. So in general with puberty, if you have a daughter who's not gotten her period by around age 15, that is a good time to consult a doctor to take a further look and do some tests for her. So during the time of change, what you can do as a parent is just to start educating your daughter however best she learns. I think for a lot of girls, visual is good. There's a lot of resources out there now, which is great, including the internet, that can help you with pictures, very basic pictures if you need them. You know, one of the things is to make a picture book to show the various stages of puberty and what's going to happen. You know, you can even take a picture book and show hair under the armpits and what you do with that and how you have good hygiene with that. You know, pictures of deodorant, pictures of shaving. You can make books that have steps of what to do. So what do you do in the morning with your underarms, and what do you do to keep your teeth clean. And again, another picture book would be great to do for your period. What do you do? What are the steps that you take when your period comes? You see blood. When do you put a pad on? Show a picture of when to change the pad. So things like that really tend to help girls learn what they need to do. The biggest thing I think to teach is that what's happening to their bodies is normal, that we've all gone through it, and it's okay, especially with bleeding. A lot of people get really frightened about seeing any blood coming out of their bodies. So I think good education in letting them know that this is normal, it's part of being a woman, it's part of growing up, that it's actually good, it's healthy to have a period. In a way, it's your uterine lining cleaning itself out. You would want that. You don't want it to build up in there and stay in there. That the subject is, it's okay. It's okay for you to talk about it with her. She doesn't have to be embarrassed. The ages 9 or 10, I think, are good ages to start talking about these things, because they usually understand well enough. And a lot of times they'll have friends that talk to them about this as well. So they've already noticed what's going on with some of their friends. I think with any girls, disabled or not, practice putting pads on and taking them off. Get used to wearing them before the period actually comes. Find a style and a size that fits your daughter, and give her a good supply. Let her have them to do with what she wants to practice in privacy. Teach her that periods are private, that you can talk to mom and dad, teacher, school nurse, but nobody else. And of course, review where to take pads on and put them off, where to dispose of them. You might even want to make a plan of what to do at school in the very beginning. Some sort of list, even with pictures, of when to change a pad, maybe around classes. Look at times and say, okay, after a couple hours, this would be a good time to go change your pad, whether you need to or not. Tampons are tricky for anybody, and just depending on what the disability that your daughter has, it may be something that you end up doing for her, and she never can do on her own. They're difficult, but the great thing is that there's a lot of resources now to learn how to put pads on. The one link that I have on here is great because it's a video of a couple teenage girls talking to their sister who's going away to summer camp, and they show nothing graphic, and they show basically how to put a tampon in. No body parts are shown in that video, and I think it's a good, at least an entrance one to show. But tampons are hard, and I think definitely for down the road in advance, but certainly important here in Florida with all the swimming that we do. So one of the great things that comes with starting your period is PMS, as we all know, which it stands for premenstrual syndrome. And some women never get it, and some women really suffer from it. And it can really vary from woman to woman. It can also vary with month to month. Some months are better than others. Some of the ways that we cope with these mood changes just has to do with how severe they are. So one of the things that we can do as parents is to help keep a calendar of when the period begins and ends. And now with iPhones, they have great free apps that are so user-friendly that you can teach your daughter to use, and have one that you look at yourself, and you can mark on there when your period begins and ends. You can also add little comments of when somebody feels bloated or moody or tired or has cramps or pain. It's good to keep these calendars, because when you do go in to see the doctor, it's really helpful for us to see what's going on. And the way that we all count how far apart our periods are different. And these apps really help because, again, visuals are great, even for doctors. And for me to look at a visual of an app and see what the period's been doing really tells me a lot about what I need to worry about and what's going on. So that's a great thing to do. You know, a lot of women who have Down syndrome have thyroid disorders, and one of the ways that you can find a thyroid disorder, and anybody, is when they start to have their periods and they're initially pretty normal, and then all of a sudden they're very irregular, where they start skipping periods. That can signal a thyroid disorder. So it tells us that that's a good thing to check for. And think of your thyroid as the control tower for all the rest of the hormones in your body. So it affects just about everything, including your female hormones. Using pain medicines to help with cramps is a lifesaver in this day and age. We're so fortunate to have over-the-counter Advil and Aleve, which are ibuprofen and naproxen are the generic terms. They're in a family called nonsteroidals. Not everybody can take those medications. Some women who have acid reflux or stomach issues can't take those. Other people that have bleeding disorders or are on blood thinners can't take those medications. But for most healthy people, they're great. You can start with the dose on the bottle, but even with the over-the-counter medications, you can actually take a little bit more. The best thing to do is ask your doctor about the appropriate dose for your daughter's size and weight. But you know, in general, okay to use the dose on the bottle unless she's under 100 pounds. But those work best for cramps. And the way I tell patients to use those is if your period's predictable, start the ibuprofen or the naproxen early. Don't wait until the cramps get bad, because pain cycles are difficult to break once they get going. But if you can get that medicine going early, you may not need to take as many doses, and you can break that pain cycle more quickly. So if you have a daughter with a very regular period, and you know it's going to start on a particular day because your app tells you it probably will, get that dose of ibuprofen in early in the morning, and then she may never have bad cramps. Most of these medications, you can take them with naproxen, you can take them twice a day, and with ibuprofen, you can take them around every 6 hours, as long as you have food in your stomach. I have some patients who have really heavy, crampy, painful periods every month. And they get to the point where it's interfering with their daily life, including school and activities that they're trying to do. So most of the women that get sent in for me in their teenage years are for this reason. And a lot of times we'll talk to them about going on birth control pills or on one of the other hormonal implants or shots to just really suppress or even sometimes stop the periods. Some of the women, we can stop their periods completely. Other women, we make it so they only have a period every 3 months. But there's a lot of things that we can do these days that are reversible and not surgeries. They're not invasive, that really help. And even though it's birth control, we use it just for hormonal reasons. It also seems to help a lot with mood changes and PMS as well. And then for those that just need something natural to help them with PMS, I usually talk about vitamins with people and activities and diet changes. So the advice that I usually give to everybody for PMS is make sure that you exercise, and especially during that week or two right before the period, when you crave sugar and carbs, I mean, that's what you want. You want chocolate or bread. Actually, it's the worst thing you can do, because when you eat a bunch of sugar during that time, your blood sugar rises and then it kind of crashes, and then you feel worse. So it makes you more edgy and moody than ever. So don't give in to those cravings if you can help it, or really make sure that you eat a good amount of protein with that sugar at the meal, and you can balance that effect a little bit better. But I usually say for people suffering from PMS, really avoid sugar during that time. Try to exercise more, even though you don't feel like it, because what you really want to do is sit on the couch and eat a bag of chips. But what will really help you the most is to try to get out there and exercise, drink lots of water. And the vitamins that are pretty harmless that tend to help some with PMS is I really like vitamin B6. Usually the dose is 25 to 50 milligrams a day. It doesn't matter so much because it's a vitamin that you get rid of. You pee it out if you don't use it. It doesn't store up. It doesn't become toxic. But B6 kind of helps keep the fluids off. Vitamin D is really important. And 1,000 international units a day is usually the dose that I tell people because it's a safe dose. There are women that have low vitamin D whose doctors tell them to take much higher doses, and definitely listen to that. But if you haven't had that be a problem, taking 1,000 a day is really going to help with how you feel. It's going to help your bones as well. And then lots and lots of water. Can't stress that enough. Some girls, some women who have intellectual disabilities, because of some of the other issues that they have at the same time, can have really pretty severe cyclical behavior changes. So things that are worse than what we would call just premenstrual syndrome. Premenstrual syndrome is really what most of us get the week before our periods, and we just feel more edgy and moody, but we function fine and we don't disrupt the people around us. Some of these girls, a small percentage, will have really severe changes, and this is where we need to step in as doctors and help. Some of them have temper tantrums, become self-abusive. Some people get seizures from the hormone changes. So depending on what your daughter's disability is and how well she can communicate with you what's going on, first of all, just make sure you don't think that it's a pain or discomfort related situation. Try to make sure that you can either have her tell you through pictures, or just knowing your daughter so well, try to figure out if that's the issue and treat that if you need to. But some of the other things that we use for these women that it's just completely disruptive to their life, how they become, that's where we use oral contraceptive pills, birth control pills. That's when we sometimes use the hormone shots. And we also use some of the SSRI medications, which are Prozac and Zoloft, and some of the antidepressant medications actually work really well with these severe mood swings. I think that there is a form of depression with it, but there have been studies where you can take these medications just during the time before the period. So you would be on it for 2 weeks and then off of it for 2 weeks, and sort of going off and on so that you don't have to take it all the time. It really tends to help. Some of the books that I've used along the way when I was on the Down Syndrome Board and some of the talks that I've done for them, I really like the American Girl series. I think that the books are great for younger girls. They have some good pictures. They're very appropriate. What's Happening to Ellie is a very simplified book. So if your daughter has autism and the American Girl books are just too much for her, this is a great book. And some of the Down Syndrome Health Guide books have been fabulous for parents to read and know what's going on. And I know that you guys have some great resources that you probably know already through your journeys with this. So I'm going to stop here for a minute and just make sure nobody has any questions from what we've talked about so far.
Okay, so far there's no questions, Dr. Logan.
Okay, we'll keep going then. All right, so one of the things that is hard, I think, as a parent to talk about with your kids, all parents, I have trouble. I thank goodness that I didn't get a daughter because of what I see every day. it would be tough. I'd probably never let her out of the house. It would be scary for me. It's a lot easier for me to help other people, I think, than it would have been for myself. So God gave me boys, I think, for a reason. But talking about sex is important. It's there. It doesn't matter what your intellectual disability is. You're going to have sexual feelings, and they're so basic. Everybody has them. I think being able to understand them and talking about it is important. So start with the basics to help decrease any fears about what's happening to her body. So again, a lot of visuals, pictures, name the body parts appropriately. Try not to use slang terms, but figure out what you're comfortable with in your family. But I think knowing what your daughter can handle, you just go slow with letting her know what's going on. Explain the symptoms that come with puberty. Explain that the moodiness and the behavior changes are going to come. Laugh about it a little bit. It helps. And also talk about the feelings that you get when there's a boy that you like and what the appropriate feelings are, what the appropriate responses are. If you have a daughter that has a good understanding of the basics, then you can start talking about what periods have to do with having babies ultimately. It's complicated for everybody, and I think you just get to a point where you feel like it's okay to go to the next level and talk about it more. The big issues, I think, with having a daughter with intellectual disabilities would be to teach her healthy sexual behavior, what's appropriate and what's not, and that her body is hers. She needs to guard it. She needs to take good care of it, and don't allow anybody to take advantage. The statistics that are out there about women and sexual abuse, it's frightening. I mean, with women with intellectual disabilities, it's reportedly 50 to 80% of these women have been sexually abused, and that's the reported abuse. Who knows what it really is, what never gets reported. So, I mean, that would be really scary as a parent. I think this is the one area where you can't be too protective of them. And this is where the information for them is crucial, because if they're out there and you're not with them 24/7, they're going to be exposed to this as they get older, and they need to know what they need to be saying. Teach them that both people need to engage involuntarily, that it never should be one-sided ever, that they can't be forced or threatened to have sex, that they're not supposed to have sex for money or gifts, that it's not proper to have sex with children or blood relatives, that it's private, and that even though you had sex with somebody before, you don't have to have sex with them again. And that's what all of us as women need to know and realize and talk about. So it's okay to say no. So definitely something to talk about. I'm sure that there's some good information out there on how best to do it, but it's important and it needs to be done when you have a daughter. Birth control options, which are really how I make my living every day. This is what I see. These are the things that we can talk in as much detail as you guys want to, but I'll go through the categories one at a time, basics. So the first category of birth control is the barrier methods. There's a lot of them out on the market these days, and most of them are over the counter. A lot of them can be difficult to use for women with intellectual disabilities, and it just depends on I think the training and how comfortable they are with their bodies. A lot of these women who are not even going to be able to do pap smears very readily or exams very readily, I think will have a lot of trouble using most of these barrier methods. But condoms are the best thing to use because they keep people from getting sexually transmitted diseases, or they decrease the risk of getting sexually transmitted diseases. I heard a statistic the other day here in Orlando that HIV is back because the teenagers are not as afraid of it as we were in the 80s, and it's back. It's around. I guess because you can take a pill and keep it under control, HIV, that it's okay to risk. So that's alarming to me. Thankfully, I have not seen a lot of it yet in my practice. Condoms can't be used if you have a latex allergy. So either the male or the female. If they're allergic to latex, you can't use the latex ones, which are the best to give STD protection. There are other types of condoms out there, sheepskin, lambskin. They have bigger pores, so they allow viruses to get through a lot easier. So they're okay with helping prevent pregnancy, but they're not as good at keeping STDs away. The diaphragm, which is a prescription, has been around for a long time. It's not hormonal. And the picture down on the left side is actually a picture of a diaphragm in the pink container. This is something that you have to go to the doctor for and be fitted. It has a lot to do with how big your vaginal canal is and how big your cervix is. If you've never had a baby, your cervix tends to be small, so you can have a small size. This needs to be put in the vagina by the user, and spermicide needs to be used with it, and it cannot be removed for 6 hours after intercourse. It has to give enough time for the spermicide to work. So it's a little tricky. For those of you that may have used it over the years, you have to use it right. It can't really go anywhere except for out, but it has to stay in there for 6 hours. Cervical cap is the same thing. It has to be fitted to your cervix size, and also has to be used with spermicide and left in for about 6 hours. The cervical cap is the picture in the bottom middle. The contraceptive sponge is over the counter. There were some issues with these sponges a while back with infections. I believe that they're all pretty safe now. And they have spermicide in them. And they're not super effective. They're better than nothing. And they just need to be put in the vagina, and they kind of go up where they need to go. You push it in as high as you can. But again, a lot of these methods are difficult for anybody, and depending on what your daughter's dexterity is, it might be hard for them to use. Birth control pills or oral contraceptives have been around for many, many, many years. And in my mother's era, back in the 60s, 70s, they used to be very high in hormone levels. There were some problems back then with them being so high in hormone levels. In my day now, the birth control pill hormone levels tend to be very low. And what most of the feeling is that when we use these nowadays, we try to use a very low estrogen level to reduce the amount of side effects and risks to people. Birth control pills are great at preventing pregnancy. The effectiveness reaches around 99%, but most of the statistics that you see have lower percentages than that, and the reason is because it's user dependent, meaning, if you take your pill at the same time every day and don't miss any, you should get that 99% effectiveness. But being the humans that we are, with busy lives, if we don't get them on time, within a few hours of being on time, or if we miss them, then they're not as effective, and there's a higher risk for pregnancy. So being taken at the same time every day is important. It doesn't have to be exact, like I said, but within a few hours. If you normally take them in the morning, you should take them, before noon in the morning. There are some side effects that make these not a great option for some girls. And if you have a daughter who's immobile, if she's wheelchair bound, or has had any blood clots in her legs before, then this is not a good medication for her. Some of the seizure medications that patients are on will interfere with how well these birth control pills work. So we either need to give them a higher dose of birth control pills or use something different. So that is also something to know. The good thing about these is it really helps control the bleeding. And so for a lot of my patients that I see that come to me from the pediatricians with heavy periods, this is the ideal medication to put them on. We can make it so that there's 4 periods a year. There's actually brands and generics out there that are designed in the pack for you to take them for about 90 days at a time. So you go through the 90 days and you finally get a period. It makes it very nice for summer vacations. But even with the regular monthly periods, they're going to be a lot lighter, a lot less crampy on birth control pills. Sometimes we have to adjust what we put people on. We generally start with a kind of a low dose, like I told you, but depending on the woman's body size or just how she responds to the pills, sometimes we have to change the doses around or the formulations. It's very common to see a lot of irregular bleeding in the beginning. So the first 1, 2, or 3 months that you're on birth control pills, you can really have a lot of what we call breakthrough bleeding, where you have annoying spotting every day. Doesn't mean that there's anything wrong. It's just a lot of times your body's just getting adjusted to the pills. And after that 3rd month, if things are not right, then that's when we look at making changes. The biggest side effects on birth control pills, the scary ones, are blood clots in your legs that can go to your lungs, called a pulmonary embolus, and that can kill you. So that needs to be taken seriously. There are families that have histories of early strokes or disorders that cause their blood to clot a lot more easily, and those people in those families should really stay away from birth control pills. There's also people that have liver issues, high liver enzymes, probably should not be on birth control pills. Obviously, if you're pregnant, you shouldn't take birth control pills, or if you have cancer. And then there's patches and vaginal rings that have similar hormones. So one of the vaginal rings, one of the brand is called NuvaRing, which is a little silicone type ring that you put in the vagina once a month. I think this is a good option. If you have a daughter that you can at least be comfortable with, or put a small tampon in, then a vaginal ring they wouldn't notice at all, wouldn't feel. And what it does, you put it in once a month and it releases hormones over time. So you put it in at the beginning of the month and you take it out 4 weeks later, and they get a period very similar to being on birth control pills. It's the same type of medication, tends to be a lower dose, and the great thing is that you don't have to swallow or chew a pill. You put it in vaginally so it doesn't go through the stomach. There are also birth control pills now that are chewable, just so you know. And then patches, there's one birth control patch out. I don't use it a lot because it tends to be a higher estrogen dose, but for those women with the seizure disorders where it would really be a benefit for them to be on some sort of hormonal treatment, that would be a good option, because it's a patch that you put on once a week and keep changing out, and again gives you the same benefit with your periods. The next birth control that is fairly popular with the teenage crowd right now, I should probably say popular with the parents of the teenage crowd, is the birth control implant. The brand that is out right now is called Nexplanon. There have been a couple of versions. Some of you may have had the one back in the day that had 6 little rods that they put in, and then they changed it to 1 rod, and now this is the final product. Seems to be safe. The picture shows its size is not big at all. It's about the size of a matchstick. And this is inserted under the skin of the arm. You can feel it in there. It's really superficial, just under the skin. It doesn't go deep into the muscle. It's something that just about every OBGYN office I know can place. Even the nurse practitioners can put these in. And all it requires is somebody being able to hold their arms still. We put a little bit of numbing medicine or lidocaine in the skin So just like going to the dentist, that's the only thing that you really feel is that little bee sting. And then the rod, make a tiny little incision for that rod to go in. It slips in, and then we don't even put stitches in. We take a little steri-strip, which is like a little piece of medical tape, and we place it over the incision and close it up and bandage them up, and they're good to go. It lasts up to 3 years. It prevents pregnancy, and it controls the amount of periods. I will tell you that it doesn't control the periods as well as birth control pills do, because it's progesterone only, so it doesn't have any estrogen in it. So it would be great for those on seizure medications or for those that have the blood clotting disorders. But progesterone type birth control tends to make your periods lighter, but they're not very well regulated. So what they say and what we see with this is that you're not going to bleed more than you are going to, but you can't predict it quite as well. I think that over time what happens is you sort of get to know when your bleeding's going to be, but there's no little pack to look at like with the birth control pills where you know you're going to get your period in that last week. Depo-Provera is the brand of, and there's now also a generic depo-medroxyprogesterone acetate, which is the birth control shot. This is a once every 3 month shot. It can be given in the office. It's a shot that goes into your muscle, so it can be put in your arm, just similar to how a flu shot would go in. And it makes periods lighter over time. So many girls, usually after about 6 months or 2 rounds of shots, they don't get a period at all. And it's really nice. So when you have your patient that's really suffering from heavy, crampy periods, or she just can't take care of them where she's at in school, or it's difficult at home, this is something that you can do that's relatively easy. It's very effective for pregnancy because there's no user failure. So as long as you get your shot on time every 3 months, your chance of getting pregnant is really low. It does have a side effect of weight gain. Birth control pills really don't anymore, but this Depo-Provera shot can. And what I find is the girls that are prone to gaining weight will gain weight with this. The really lean girls who don't have an issue, they're fine. It also will show in women that are on this for several years, there will be a decrease in their bone density. So you do have to make sure that they're taking calcium in their diet and they're getting vitamin D and getting exercise. The bone density changes will reverse after you go off the medication, but while they're on it, there are a little bit higher risk of an injury or a fracture. If they're young girls, it's not going to be an issue, but if you're on this injection in your 40s, probably more of a worry as you approach the older ages where you have to worry about your bones more. IUDs, we currently have 3 types back in the marketplace that are all safe. They've been around for a long time now. They really got a bad rap back in the 70s, but seem to be very safe. And in a lot of the European countries, this is the #1 birth control method. This is a tricky thing for a woman that has an intellectual disability. It's a tricky thing for people that don't. It's uncomfortable putting it in. It's great birth control. And the one called Mirena actually makes the periods lighter, very similar to the birth control shot, except without the other side effects of weight gain. And all of these IUDs, because they're not there's no room for error with the use. As long as they're in the right place, they're 99% effective. So the longest acting one is 10 years, and that's Paragard. That is just a non-hormonal, copper-based little plastic IUD that goes in. The only people that can't use this are people that are allergic to copper. The Mirena has progesterone in it, and so does Skyla. These are all tricky to put in, though. If somebody hasn't had a pregnancy before, they tend to be uncomfortable and usually are not going to be the first line for your daughters. But we could use sedation if we needed to. If this was the appropriate birth control, that's an option. You can see the contraceptive failure rates that are the realistic ones. And even though birth control pills, if you take them right, it's 99% prevention of pregnancy, a lot of people mess up with them. So the IUDs tend to be the best, as you can see. The injection, the failure with that is usually not getting the shot on time. And condoms and diaphragms, barrier methods, they're just not quite as good. Emergency contraception is now available in Florida over the counter. And if you ever need to use it, what you need to know is that you have to go back where the pharmacist is to get it. It's generally the ones that are out. Plan B and Next Choice are two of the brands. They're progesterone only. One of them is 1 pill, and I think Next Choice is 2 pills. But these are to use if there's been a sexual encounter or sexual assault. They need to be taken ideally within 24 hours of the incident, or if a condom breaks. You can take it 72 to 96 hours, but the chance of it working is less, much, much less. And if you're unlucky enough to have had a sexual encounter near ovulation, within a couple days of ovulation, it's less effective. So it really has a lot to do with where you are in your cycle as to its effectiveness. But if you get in a situation and you need to use this, you can use it. It probably will cause a lot of irregular bleeding within a few days, which actually would be a good sign that it probably worked. And what it does is it blocks the eggs either from being released, so it'll block ovulation if it hasn't already occurred, may stop fertilization if you've already ovulated, but it's not a great thing, and it's only to use in an emergency situation. It's not great birth control, as you can see. I mean, the statistics are 50 to 90% reduction of pregnancy, so not the greatest. It does work best if you're 165 pounds or less, and so not a great option for everybody, but it is available without having to see a doctor. One of the permanent and newer procedures that we use for, we used to call it tying tubes or tubal ligation. This Escher method is called tubal occlusion. But this is an option that I actually used in a couple situations where the one patient that I used it on was a girl whose mom had rubella or German measles while she was pregnant with her. And this poor girl, she was deaf and pretty much mute, partially blind, and we did this procedure on her in conjunction with another one to stop her periods, because every month she was just making a complete mess in the house with her period, and she didn't understand. And there was also an issue with this patient possibly needing to be institutionalized as her parents get older. And so they came to me, and we did all the right court things, legal things that we needed to do, and under anesthesia for this patient, performed the Escher procedure, and at the same time did what's called an endometrial ablation, where we burn the lining of her uterus to try to get rid of her periods. But we do them both together the same day, which you normally don't do, but in her situation was the right thing to do and really helped those parents out a lot. But typically, we can do this procedure in the office under light sedation, or we can do it in the hospital outpatient, but under very light general anesthesia. There's no incisions. There's nothing that can be pulled out. It can't go anywhere. The procedure is done very much like what a DNC is, if you're familiar with that. You go through the cervix and dilate it a little bit, open it up, go through with a device about the size of a pen, and goes through it, puts little spring-like looking coils just inside the tubes from the inside, and what happens is your body scars around the tubes and blocks. And so 3 months down the road, generally we would do just a quick dye test in the office and make sure they're closed, but it scars down the tubes and it blocks the egg from moving through into the uterus. So it's a great non-hormonal, permanent way to sterilize. There's really no recovery time, but it is really requires a lot of informed consent on the patient part and the parent part, and needs to be discussed. It's definitely, more of a procedure, a bigger decision to go through. But we try to do it this way rather than tying tubes or burning tubes or blocking tubes that require incisions and more risk and abdominal procedures like laparoscopy. So this has really sort of changed the face of tube ligations. We have ACOG is American Congress of OBGYN that governs my board specialty, and they have this statement. They have opinions about what to do, and of course it's something that needs to be talked about, and everything needs to be considered if you're doing something permanent like this. So we'll stop here for questions because I know that was a lot. If you have anything specific, let me know.
Okay, I don't see any questions at this time.
Okay,
Oh, wait,
we'll move on.
I'm so sorry. There is one. Oh, no.
Okay.
No, I'm sorry. There's not. It was just a comment. This is great information.
Okay, good. All right, so the big burning question, to do pelvic exams and pap smears or not, for all of us. So I will give you my opinions for right now. They're subject to change over time because even pap smears for the mainstream population have changed. So the new guidelines for pap smears for everybody is that we don't start them till age 21. And in my practice, in women with intellectual disabilities, I do not force the issue unless they're sexually active. So even at 21, when the rest of us are supposed to go in for our first exam, I never push it, because cervical cancer, now we know what we didn't know 20 years ago, is that cervical cancer can only occur, except in rare, very, very rare cases, but we're going to ignore those because for the most part, it can only occur if you've had intercourse and you've been exposed to the HPV virus. And all of us have HPV viruses, but just a certain few are very high risk, and they can make the cells of the cervix change and grow into cancer. So if your daughter, if you know that she's never had sex, you're sure she's a virgin, you do not need to worry about pap smears. You don't need to push the issue. And my recommendation would be to start going to the OBGYN and developing a relationship before we have to go there. And, if down the road they want to do a pap smear because it's part of being a woman, absolutely, but don't force it, because realistically, they don't need it if they haven't had sex, period. Now with everybody, if you have not had an abnormal pap smear in your lifetime, or it's been many, many years and you didn't have a very bad abnormal pap, we only do pap smears every 3 to 5 years. So you guys, when you've gone to your doctors, you're probably hearing about this now. It's a little unsettling if we're used to going every year, but it's really, you're still supposed to go to the doctor every year for your pelvic exam, but we don't always have to do the actual scraping pap smear part. So that's a good thing. So it's okay to allow a little bit of time between them. The other way that we can do a pap smear is sort of a blind procedure, because we're checking for this HPV virus. I think in California, they don't even do the scraping anymore. They actually just put a little probe or swab in there and check for the high-risk HPV virus. And if you don't have it, you don't need to do anything more. So we're finding that if you don't have that virus, you're not going to have anything significant with your cervix. So that's a way to do it. Just put a little Q-tip swab in there without using the metal speculum, which is so uncomfortable, and that can work too. The pelvic exam that we would still want to try to do every year after age 21 is a couple things, tells us different things. So we look on the outside, make sure everything looks good. Some people can get skin cancers on the outside of their vaginal or vulvar area. We need to look for that. Most dermatologists don't look down there. We need to look that everything looks right, that things aren't swollen, that there's no infections or lesions or bumps or anything to worry about. We can usually tell if the hymen's still intact just by looking kind of very gently. Speculum examination looks at the vagina and the cervix, and that's also where, when we do the pap smear, if we're going to, is when that speculum's in. And the bimanual exam is just where we usually put 1 or 2 fingers in the vagina with some lubrication and press on the belly on the outside and check the uterus, cervix, and ovaries just by feel. But there's nothing that's really proven that that bimanual or invasive exam can't be looked at other ways. So in some of my patients that they're just not comfortable with me doing any kind of internal exam, I'll look at the outside. And then if we need to worry about the uterus and ovaries, we can always do an ultrasound, which is painless. And on the outside of the abdomen, they just have to hold their bladder after drinking some water for us to be able to see. But that's a good option. And really for women that are not having any symptoms at all, it's just not necessary to do it all the time. So this is one of those places where you really need to talk to your doctor, have a good discussion about whether you need to do it or not on your daughter. And I think the big thing is to just develop a relationship where she feels comfortable and trusts before you go right into the pelvic exam. STD testing nowadays, we can either draw it on blood or we can even send the urine sample. These are some of the health recommendations through the ages, but basically pap smears have really skipped around. By the time you're 65 or 70, we don't even recommend that you do a pap smear anymore. Bone density tests we do on 65 and older unless you have a medical condition where you need it earlier. And vaccines, the Gardasil, which is the HPV vaccine, is something that probably the pediatricians talk about, but we do as well in our practice. So preparing your daughter for her first pelvic exam, again, use visuals, show her a picture of what will happen, help her make a list of questions she has, and it's a good time to bring that pain scale in, the picture with the faces on it with the various degrees of pain, so that if she's not real verbal or she feels uncomfortable in that situation, she can tell you or show you which picture, what's going on. It's good to bring something distracting to the exam, music, games, or a phone to do, and we don't mind that. Practice relaxation techniques before the exam, deep breathing, focus. We can do sedation if we need to, a little bit of Xanax or Valium or something just minor to get them to relax. And bribery always works great. Special rewards or going somewhere, always good for these types of first exams. But again, in my opinion, it's better to meet the person and have sort of a relationship for a while so that they can trust. This is a pain scale chart. You can find this anywhere. And for some women, this is the best thing to bring. My best resources for most of this stuff were free on these online PDFs, and these are from the Vanderbilt Kennedy Center. And the appendix especially has pictures that you can cut out. And when we were talking about the picture books, the putting the pad on, talking about periods and hygiene and shaving and everything, they have pictures for everything in the appendix. And the Healthy Body Guide is great. It's very basic, has some good visuals too, but really liked these resources. So one of the questions that I got from, I think it was Lynn or one of you guys, was how to choose the right doctor for your daughter. So I can't stress enough that word of mouth is huge. And when I have patients that are asking for specialist referrals, I always say word of mouth, because if you know somebody that's had an experience, good or bad, and you know that person and you trust that person, that's very telling. If you really don't have anybody to talk to about that, there are online sites, Vitals and Health Grades. Some of the sites you have to be careful because some people that are disgruntled will put things up that aren't not so kind. I think if you weed through them, you can tell what the real ones are versus the disgruntled person that had a high bill or something. But so those ratings are okay. They shouldn't be the only thing. make sure that when you go in to meet this person the first time that you talk to them first. And we don't even mind if you wanted to come by yourself and meet us or bring your daughter in and just have a conversation. So no examination, clothes on, sitting there and just talking back and forth, almost like an interview for a job. Go interview your doctor and make sure that that doctor is the right person, that you both feel comfortable. Discuss your situation, let them know if there's going to be any physical limitations. The more we know about your daughter, the better it is that we can take care of her, and we can also let our office staff know what we may need to do differently. Sometimes that last appointment of the morning or the afternoon is great because we don't have anybody that we're rushing to after, and we can spend more time. So those are all really important things that doctors should not mind, and if they mind, it's not the right doctor. So a couple other just loose and important things that I feel like you just should know about women's health. The HPV vaccines out there, I know that the pediatricians usually address it. You can give it from 9 years up to age 26. And the only reason why it goes up to age 26 is that they haven't done studies on older than that. There's probably no harm. If you have not had sexual intercourse and you're older than 26, it's probably still okay to get the vaccine. Because again, with HPV virus, you're trying to prevent it with these vaccines before you ever get exposed to it. So there's 3 of them out there. They have all had a lot of experience. If you're a vaccine person, you can make your own decision about these. The newest one is called Gardasil 9, which really covers the most. And the HPV viruses that you worry about the most are 16, 18, 6, and 11, which are the ones that cause the highest risk of cervical cancer and or warts. The other ones that Gardasil 9 covers are now more of the high-risk ones that can cause abnormal pap smears. But this is a series of 3 injections over 6 months. Most of the primary doctors, pediatricians, OBGYNs, we all have them in the office. And it's just something to talk to your doctor about and make a decision about what you want to do. Mammograms, doesn't matter what kind of disability you have, the recommendations are the same. For the groups that are not high risk. So for those that are not high risk, screening mammograms should start around age 40, and they should happen every 1 to 2 years. And that's forever. I know there was a study that came out a few years ago with one of the government sites, and the problem with that study was they were using the old mammogram machines in their study where they used to print out the films on the x-rays, and now most in town here are all digital, and they're better and they're picking up more, and the docs are using software to find things. So definitely try to do these every 1 to 2 years at 40. If you have a high family history of breast cancer, that's a whole different ballgame. And so that's with a high family or the BRCA genes in your family, you need to talk to your doctor about what the plan would be with that. But for low-risk families, 40 and then every year, I would definitely talk to the center where you're going to go ahead of time and just say, you know what, my daughter may need a little more time. Definitely work with your daughter as to why she needs to have this. Show her with pictures and try to go through the steps as best you can about what's going to happen during the mammogram. And I always tell people to do your mammograms right after your period's over because your breasts are less tender at that point in time. One of the other issues that you do have to worry about in some of your daughters with their medical conditions is thinning bones or osteoporosis. And the things that lead to thinner bones, body type is the big one. If you have a daughter whose BMI, body mass index, is below 20, which means they're really lean and petite, they're going to have more of a risk for osteoporosis as they get older. If they're having very irregular periods, like they're not coming very often, that usually signals that their estrogen levels on the low side. So that's a risk. Hypothyroid is a risk. Just taking Synthroid or thyroid replacement, that medication can thin the bones, but you have to take the medication. So you just have to address how to take care of your bones. Some seizure medications, steroids, early menopause, those that don't have a lot of activity or exercise, and those that are vitamin D deficient all have a higher risk of osteoporosis. So they may need to be tested earlier than 65, and they all should have calcium in their diet, and talk to your doc about taking extra vitamin D. Like I said, about 1,000 a day is pretty safe. Some of the women with Down syndrome will have some early aging, and what we see a lot of times is early menopause, which also leads to early bone thinning, osteopenia, and osteoporosis. That's what that means, early dementia. Some of the women that are Fragile X, either carriers or with the disorder, will have early menopause and infertility issues related to that Fragile X chromosome. One of the things that we see a lot of is, like I told you before, women that have really bad periods, and that's usually where I see them when they're younger than 21, when they come in from the pediatricians. We have a lot of options. Abnormal uterine bleeding is pretty common with Down syndrome, hypothyroidism. More obese women have heavier, more irregular periods, and that's because with obesity, you're making sometimes more estrogen than you need to, and that cycle feeds back with the rest of your hormones and causes you to have irregular periods, and also causes the lining to build up really thick, which causes the heavier periods. Some of the antipsychotic medication, which works in the brain, can cause abnormal periods. Like I told you guys before, apps and calendars, pad counts help us to know what's going on and what the right thing to do is, and birth control pills, hormonal types of treatment, and surgery, which is the endometrial ablation, which I'll tell you about, is a very low invasive, good surgical option these days. Endometrial ablation is something that it's newer. It's been around for at least 10 years. And it is considered permanent, so you would never want to try to get pregnant after having this done. And you do need to also try to prevent pregnancy while you have this. So if your tubes aren't tied or blocked, you need to do something else to keep from getting pregnant. If you did accidentally get pregnant after this, you'd have a high chance of miscarriage and could have some serious health consequences. But what it does is it burns the lining of called the endometrium, or the lining of the uterus, and for people that it works the best on, it completely stops their periods without doing anything hormonal. So you still feel normal, you don't go into menopause, but you just don't bleed every month. Some people still do keep their period, but it's much, much lighter. The effectiveness that they stress is about 70% effectiveness for most people. And the 30% that this procedure doesn't work for, those people usually go on to have hysterectomies because they have bigger issues that need a bigger surgery. So again, it's not birth control, and it's not for people that desire future pregnancy, and it is preferred over hysterectomy in women with intellectual disabilities because it's minimally invasive without any incisions. Can be done in the office under sedation. Some of the resources which will make this available, so you don't have to frantically jot these down, but these are some of the ones that I used in the talk, and some of the ones that we have about the ablation sites are great. They show videos as well. The takeaway points are really just the biggest thing, I think, with these girls is to use visuals and try to teach them how they learn the best. Give them more knowledge and information. It will help by the time they get to the point where they're having periods. Find a doctor who's going to work with you, and competition is stiff in this town. There's a lot of good OBGYNs, a lot of good family doctors, primary doctors, pediatricians. You should be able to find somebody that will work with you. And if they won't, they're not the doctor, because the last thing that you need is a traumatic experience for your daughter, and then she's afraid to go back over and over. Always best to prevent pregnancy, and that there are a lot of birth control options these days which are a lot of times used for other reasons like bleeding. So I'll take any questions if you guys have any.
Okay, let me check that out. We're getting a lot of comments, great information. Um, and somebody said, yes, we are going to give a copy of the PowerPoint, so you'll have all the resources and everything that Dr. Logan has provided. Um, I was wondering, when we talk about sedation, if we can't get any of those medical procedures done, like the mammograms, I mean, after we've exhausted everything, will they do sedation for these tests or no?
So I think the big thing is deciding how important the test is. If it's just for screening, you may not need to do it at all. If somebody's not having symptoms or a lump, but say your daughter has a lump and you really need to get that evaluated, you could have her do an ultrasound to look at it. And if they feel the need to biopsy it, then it would bypass the whole mammogram experience, which might be good. Because mammograms are mostly for screening. So when there's a problem there, I feel like sedation and doing different things probably would be the best. For screening mammograms, it may or may not be worth it to go through that. Or if you do it, a couple of years in between. They can't be so sedated that they can't stand there, because it's a standing up procedure for the mammogram. So Valium or Xanax, if that's good enough, that's pretty easy. But they have to be able to stand and follow directions and hold still. It's a quick procedure, but they have to hold still. So that's a tricky one. If absolutely nothing's going to work, then you have to ask, okay, how important is it that we really do this test?
Okay. Wow, this was such great information. I can't thank you enough. Lynn, do you have anything to say?
I have a question. Every time we go to the pediatrician, they bring up the Gardasil vaccination. And so far, I have chosen not to give it to my daughter. How bad of a mother am I being?
You're not bad at all. You certainly don't want to give your daughter anything that she doesn't really need. And if you're watching her 24/7, and nobody's going to get to her, she's not going to have intercourse, then she doesn't need to do the vaccine yet. If she gets in a situation where you're separated from her, goes away to camp, is away for hours of time where you're not around or somebody else isn't around watching her, then that's where I think need to consider it. Because with that vaccine, it doesn't do as much good if you've already had sex. It can't help you for what you've already been exposed to. It only helps you to prevent. So you want to get it in before you think they're going to have sex. So even with my kids, because they give it to boys, I have not given it to them right at age 9. I've been giving it to them when I can talk to them about it a little more, and before I feel we're getting to the age where I have to worry about them having sex is when I give it to them. And it's also not for everybody. You may never need to take that vaccine, and it's okay not to take that vaccine either. None of us had that vaccine. So it is something that you need to talk about and think about, and you're not a bad mom for not doing it. I would say that majority of people are not getting it. It's still newer. So people, I think, are sitting back and watching and waiting. But from everything that I've seen, it seems to be safe. No side effects unless you're allergic to what's actually in it. Or if you pass out or faint and hit your head after the vaccine, that's usually where they have the reported side effects, something like that.
Okay, and then the other question I had was that first appointment that you talked about, as far as like kind of doing an interview. Would you recommend that we bring our daughter to that very first one? Because I feel like if I were to go, I would be talking about her, but I don't like to talk about my daughter in front of you know what I'm saying?
Right, exactly. So I've done both. I've had both, and I think it depends on your preference and hers as well. So, if your daughter, I think that if there are a lot of issues that you need to address that maybe you don't want her to hear, then I would come by yourself. A lot of times with these women with Down syndrome, they come and they, they understand and they ask me questions and they interview me sometimes more than the parents even do. So it just depends on your daughter and her ability, and you know that the best. So I think what your comfort level is the best thing to do. And all you would do is call for an appointment and ask for a consultation. That's all you have to say. And that just means talking. So it doesn't matter what you're talking about. It could be anything, but we're giving you a block of our time to talk about whatever it is that you need to talk about.
Thank you, everybody. I just wanted to make a quick comment because my daughter is nonverbal and she's 20 now, but I was very nervous going through the process and getting ready to hit puberty and all those different things. And I'm so thankful I attended your seminar at the Down Syndrome conference. And one of the helpful tools was, I used her augmented communication device, and the school had programmed pictures for her. So we were able to, talk about it through her communication device. And so we did that way in advance, and we made it an IEP goal for her. And everybody was working with her, talking about it and everything like that. And then one day at school, she got her period. And we were preparing her, with using the pads and everything way and before, like you had suggested. And so she got her period at school, and the nurse called me and she's like, Miss Brunell, just want to let you know that Ashley got her period today. I say, I'm coming to pick her up right now. They're like, no, Anna. She's doing very good. She put on her pad and she doesn't seem to have any cramps and everything, and she's going along. And I'm like, are you sure? I'll come get her. And she's like, no, let her stay. So, by all that preparing and everything, my daughter transitioned into that process very easy. And to this day, she does her pad and, she does really good. And so I believe in what you say, prepare them way ahead of time, because by making it an IEP goal and her mastering her goal, she really came through that process very quickly. So thank you for all your information.
That's awesome. You're welcome. Very welcome.
Yeah, and I second that, Anna, because I know, same here. I mean, I was caught off guard, even though I said for years I would be very proactive. And anyway, when it happened, I was so caught off guard. But like you said, the American Girl books were awesome. And today, I mean, it's so funny because I'll have family members say, and then they whisper, how does she deal with the period? And I laugh because it's like, she does great. She really does great. She knows what to do. She, one of the things that we didn't mention, but it may be a given, but the flushable wipes are a great little tool for them to use. My last question, Dr. Logan, is how do our families find a good doctor for their daughters who are adults? Because most of them are covered by Medicaid. And that tends to be a challenge. Yeah,
I know. It just depends on. I think that word of mouth is good, and I think that the resources you have, like people that like Amy Van Bergen and some of the people, Stacy Taylor, some of the people that even work with the Down Syndrome organization, they know a lot of us. And a lot of us that have actually volunteered time and work with Shepherd's Hope, a lot of us will see these individuals sort of on the side or under the radar as well, just for annual visits. We try to. So I think that, the biggest thing is word of mouth and ask. People definitely do favors for people that we like in this town that are associated with these organizations, because they're important. It's important to take care of these girls in our area. So I think there are people that will be willing to see them. And the Medicaid thing is trickier. There are good doctors that still do take Medicaid. So I can always give you guys some referrals of offices that I know that take Medicaid, Medicare. But I also know people that will do things for people just because it's the right thing to do. So that should never be a problem. And if you guys as an organization have parents that are in a situation where they're having a hard time finding somebody good, you can always call me, and I'd be happy to help out for really any specialty, because I know the good people in town to send people to, that the good-hearted people, as well as good doctors for all different specialties. So there's a lot of volunteerism going on in Orlando, which is great. And so good for you guys too.
Thank you. And I just want to let you know that there are a lot of comments coming through. This information for any of our daughters, it was great information. Thank you. And just a lot of comments on thank you and taking the time to present to us. And I just wanted to say thank you for the training. It was very good for me to talk with families who don't take their children for these appointments or physical exams because they have been afraid of the sedation process. So people are just leaving thank you comments. And
Anna, we recorded this correctly?
yes.
Okay. So I just wanted to make sure that that's out there. So if you're listening to the recording, even and you may not be in the greater Orlando area, contact your local autism chapter, Down syndrome group. You'll have different groups, and certainly Facebook is a great networking tool as well.
And a nurse just wrote, I'm a nurse working in women's health and found this very, very helpful. Thank you. And I just wanted to let everyone know that at the end of this presentation, a survey will pop up. And as soon as you leave the webinar, so if you could just complete that, that would be great. And Dr. Logan, thank you again. You're awesome.
Thank you.